vomiting and diarrhea. You know, as a GP, this is our bread and butter. We see it every single day. And while it might seem straightforward, getting that initial management spot on is absolutely critical. So today, we're going to build a solid, reliable playbook for your OPD. Let's get right into it.
Okay, picture this. The patient is right there in front of you. They look miserable, they feel weak. Your mind is probably already running through a list of differentials. But stop. What is the one thing you need to focus on right now above everything else? Answering this question right is the key to managing every single one of these cases.
And here it is. The answer. It's not the virus, it's not the bacteria, it's not the bad biryani they ate last night that's the immediate threat. No. It's the rapid loss of fluids and electrolytes. The real enemy, the thing that lands people in the hospital, is dehydration. If you can get a handle on that, you've already won most of the battle.
So here's how we're going to break this down, just like a real consultation. We'll start with a typical case, then dive into our most powerful tool, taking a good history. After that, we'll cover how to spot those critical red flags, build a rehydration plan that actually works, know exactly when to refer, and then we'll wrap it up with some golden rules you'll never forget.
Right, so the huge majority of these cases are just simple acute gastroenteritis. It's usually viral, sometimes food-related. And the most important thing to remember, it's self-limiting. The body is designed to clear this stuff out in a couple of days. Our job isn't to blast the bug with medication, it's to support the patient while their own body does the hard work.
Now, let's talk about our most powerful diagnostic tool. And the best part? It's completely free. It's the history. A focused, high-yield history is what separates a simple, manageable case from a potentially dangerous one. This is where you make your first and most important clinical decisions.
We can break this down into 5 key areas. Just think of this as your 2-minute rapid-fire checklist: onset, vomiting, diarrhea, associated symptoms, and exposure. If you get these 5 points right, you'll have a crystal-clear clinical picture in no time.
First up, onset and duration. This line of questioning immediately helps you build a differential. I mean, if the symptoms hit them like a ton of bricks just a few hours after a meal, you're thinking food poisoning. If it's been dragging on for a day or two, viral is your top suspect. But if you're looking at more than 3, maybe 5 days, you have to start thinking about a bacterial or maybe even a parasitic cause.
Now for vomiting. Look, the most important question isn't just how often. It's, can you keep anything down at all? This single question is a massive fork in the road. In Hindi, I always ask, "Pani bhi pet mein tik nahi raha hai." Can you not even keep water down? Because if the answer is no, your whole plan for oral rehydration goes right out the window, and you need to pivot fast. Next, your checklist for diarrhea and other symptoms. You want to know the frequency, sure, and if it's watery, but you need to have your radar on for 2 huge alarm bells here. Any sign of blood or mucus in the stool, and any report of reduced urine output. Those are immediate signals that this isn't a simple case. And of course, weakness and dizziness, that's just dehydration screaming at you. And that brings us to the most critical part of the assessment, spotting the red flags. Think of these as the non-negotiable signs that tell you, this patient cannot be managed safely in my OPD. This is your safety net, and you can't afford to miss it. And here they are. Severe dehydration, vomiting that just won't stop, where nothing stays down, blood in the stool, a really high fever, or if your patient is in a high-risk group, like a small child, an elderly person, or someone who's pregnant. And finally, any change in consciousness. You have to actively hunt for these. Don't wait for the patient to tell you. Ask. The rule here is simple, and it's absolute. If you find even one of these red flags, your plan changes immediately from routine OPD management to urgent action, and that almost always means referral for admission. There are no ifs, ands, or buts about this.
Your physical exam is where you confirm what you're suspecting. If the patient's vitals are stable and they only look mildly dehydrated, okay, they're a good candidate for OPD management. But if you see a dry tongue, sunken eyes, a heart rate that's creeping up, or a blood pressure that's dropping, that's it. You have objective proof of significant dehydration. The decision is made. They need admission.
So for that patient who is safe to manage in your OPD, what's the plan? Well, the top priority isn't medication. The absolute cornerstone of treatment is, and always will be, rehydration. Our #1 tool for this is oral rehydration salts, or ORS. The genius of ORS is just how simple and scientific it is. It's not just salt water. The glucose in the packet actively pulls sodium, and water right along with it, into the body through a special channel in the gut.
And the brilliant part? This channel keeps working even when everything else is inflamed and irritated. It's an incredibly effective backdoor for hydration.
But you have to tell patients how to use it correctly. This is so important. 1 packet, 1 liter of clean water. And here's the secret. Small, frequent sips. If they gulp it, they're just going to throw it back up. And here's the crucial bit of advice. If they do vomit, don't give up. Wait 10 minutes, let the stomach settle, and then start again with even smaller sips.
And here's exactly how you can explain it. I use this line all the time. चम्मच से थोड़ा-थोड़ा करके पिलाते रहिए, उल्टी हो तो भी 10 मिनट रोक के फिर से दीजिए. It means keep giving it little by little with a spoon. Even if there's vomiting, just wait 10 minutes and then give it again. Honestly, that one line of counseling is often the difference between success at home and a failed plan that ends in admission.
All right, let's talk about the big one. Antibiotics. The single most common mistake I see is giving them routinely. You should only even think about antibiotics if there are clear signs of a bacterial invasion, like that blood or mucus in the stool we talked about, or if the patient is really sick. For the vast majority of simple watery diarrhea cases, antibiotics just make things worse.
Everything else is just supportive care, the supporting cast, if you will. Paracetamol for fever. You can use antiemetics, but use them judiciously. Zinc is great. It's been proven to shorten diarrhea, especially in kids. And the diet advice is simple. Keep it light. Khichdi, banana, rice. Tell them to avoid anything oily, spicy, or heavy that will just irritate the gut more.
Okay, we've talked about the red flags, but let's just make the actual criteria for admission crystal clear. This is your final safety check to make sure no one who needs inpatient care slips through the cracks.
So it really boils down to this. If the patient is severely dehydrated and needs an IV, if they can't stop vomiting and just can't tolerate ORS, if you suspect their electrolytes are out of whack, or if any of those high-risk patients are getting worse instead of better, they must be admitted. Basically, if any red flag is still present, the decision has been made for you. It takes the guesswork out of it.
Okay, we've walked through the entire process. To make sure all this sticks, let's boil it down into a few unforgettable golden rules for your daily practice. Number 1, dehydration is the enemy, not the bug. Focus on fluid status above everything else. 2, trust in ORS. Biologically, it's more powerful and way more important than any other drug you can prescribe in this situation. 3, be an antibiotic steward. Resist that impulse in simple cases. And 4, always ask about urine output. It is your best, simplest clinical marker for how hydrated your patient actually is. So the next time a patient with vomiting and diarrhea sits in front of you, just remember, your most powerful tool isn't on your prescription pad. It's that simple little packet of ORS and the clinical wisdom to use it effectively. If you can master that, you've truly mastered the outpatient management of acute gastroenteritis.